Hello and welcome. We recognize what a unique moment this is in the world, and we appreciate you taking the time to join us. My name is Lorna Nealand, and I am the Director of Engagement at the Swedish Foundation. We are the fundraising arm of Swedish, the largest not-for-profit healthcare system in Washington State, and we're based in Seattle. I'd like to take an opportunity to thank our donors who are joining us today. Without your support, we can't continue the innovative work that we do every day for our patients. This is the second in our series of virtual calls. We hope you are able to join us for the menopause webinar in September. And if not, we will have information at the end of the call. The Women's Wellness series promotes our vision for the women's health and GYN specialty services. An extension of Swedish, the program will provide comprehensive care for women at every stage of life, including primary care and behavioral health, wellness and prevention, and specialty and surgical care. So thank you for joining us for the Swedish Women's virtual series on heart health and taking the time to answer our poll at the beginning. Who is at most risk of cardiac-related death? Men, women, or the risks are the same? It looks like 75% of you selected women, and indeed it is women, and the most at risk for cardiac-related death. We will learn more from our experts today and the risk factors in women as they age and what you can do to reduce them. In regards to how our time together will proceed, we will be asking questions to both panelists, but this event is meant to be informative and interactive. So look out for a few more polls and enter your questions in the Q&A. We will answer your questions throughout the call and then at the end. Now, I would like to introduce you to Dr. Tanja Sorensen, the Executive Medical Director for Swedish Women's Services, to talk about the vision of this new and exciting program. Dr. Sorensen.
Thanks so much, Lorna, and thank you all for joining us today. As Lorna said, we want to take care of women here at Swedish throughout their lives, and we are hoping and planning to become the primary destination for women's specialty services and GYN in the region. We are going to be focusing on coordinating care as well as prevention of disease, wellness, and aging gracefully. Last year, we got together a really great group of women who are in their 40s and above to just basically figure out what pain points were, what their needs were, how they are looking to transition into the later parts of their lives after having children or not. The themes that we heard was that women would like someone on their team who's their advocate in seeking answers and also in helping them coordinate their care. This would include taking a holistic approach that would include wellness, nutrition, and stress management. Our new program will provide comprehensive care for women at every stage in their life. We'll have urogynecology, primary care, cardiology, mental health, wellness and prevention, and then also specialty and surgical care. So as we begin to build and launch this program, we want to thank all of you who have donated and helped us get this off the ground. And in particular, we're really excited to announce a $250,000 gift, which is seed funding for the program. We really, at this point in healthcare, we can't do this without private support. So we really appreciate you all. Today, you're going to be hearing from two physicians who are really knowledgeable and wonderful speakers. First, Dr. Rebecca Dunsmoor-Su, who's the medical director for our Swedish Women's Health and GYN Services. And then Dr. Sarah Speck, who's the medical director of the Cardiac Wellness and Rehabilitation Program at the Swedish Heart and Vascular Institute. Both of these women are going to talk about why we're including cardiovascular wellness in our program. As you all correctly answered, women do have cardiovascular disease, and it is it can be life-limiting. It also can be life-changing if you have events and aren't able to stay healthy. So Dr. Speck is going to give us some tips on that. And also sort of describe what kinds of measures that you can take yourself. So I really appreciate you all being with us and look forward to hearing Rebecca and Sarah speak. Thanks so much.
Thank you, Dr. Sorensen. I would like to officially welcome Dr. Rebecca Dunsmoor-Su and Dr. Sarah Speck. Thank you for taking time out of your busy schedules to be with us today. But before we learn about you both and begin our questions, we would like to start with another poll. What are the signs of a heart attack in women? And we'd like you to check all that applies. Chest tightness, chest pain, indigestion or nausea, shoulder pain, jaw pain, or sweating. So as you are selecting your answers, I would like to ask both physicians to tell us a bit about yourselves, your journey, your current practice setting, and how you focus on cardiovascular disease in women. Dr. Dunsmoor-Su, would you like to start?
I'm happy to, Lorna. Thanks for having me today. So as many of the participants may know, I am the medical director for the Women's Wellness and GYN Specialty Services Clinic and the medical director for menopause at Swedish. And I am a board certified OBGYN, a general practitioner in that specialty. And I started my career out here in Seattle at the University of Washington, where I did a lot of vulvovaginal specialties, pelvic pain, and menopause. And really found that these were the areas where I was happiest working with women. I felt like I could do the most good, and these were really my interest areas. I then moved over to Swedish about, 7 years ago now, and worked as an inpatient provider for several years until I started as medical director for menopause, and really started with Swedish to build out this clinical service. Menopause has always been a huge interest area of mine. All endocrinology is. And I just feel like in building this, we have the opportunity to really make the premier center for menopause and women's health in the region.
Thank you so much. Dr. Speck, welcome.
Thank you, Lorna, for having me today, and thank you, Tanya, for those lovely remarks. Well, I'm a board-certified cardiologist. I've been privileged to be the Director of Cardiac Rehabilitation and Wellness Services at Swedish for now almost 2 decades. And we have enjoyed having lifestyle programs in addition to teaching people how to exercise and eat better after they've had a heart attack, but even before they've had a heart attack, which is why we're here today. My own personal journey is I watched my grandmother die of congestive heart failure at age 70, which seems pretty young these days, because there wasn't enough knowledge about why women might have heart disease or even medicines at that time to treat them. My brother had a sudden cardiac death from a heart attack at age 59. My mother died of a stroke, and my dad died of a ruptured aortic aneurysm, all of which might have been preventable had they known earlier diagnoses and had they taken some other precautions. So I really believe in prevention. I have a master's degree in public health, and I feel like the science has finally caught up with what I believe. And I know that in menopause, of which I'm a member now, we have about 1/3 of our life ahead of us. And if we plan well, that can be a healthy and rewarding life, not only to see our children get married, but to play with our grandchildren and see them graduate from high school and maybe even college. So that's my goal.
Wow, thank you both for sharing your journey. I actually didn't know that, so thank you for sharing that. Why don't we look at the poll and then we can start our discussion. So the poll was, what are the signs of a heart attack in women? And I'm just going to go through this really quickly. 85% of you selected chest tightness, 70% of you selected chest pain, 85% selected indigestion and nausea, 82% shoulder pain, 61% jaw pain, and then 67% sweating. Dr. Speck, can you go into more detail about what are the signs?
Well, the signs of a heart attack are actually all of those or any of the above. The signs of a heart attack in women are unique to women, not exclusively. Women can still have the elephant sitting on their chest when they're walking up James Street from the ferry dock in Seattle. but more typically they have signs that are not classic for what we call garden variety heart disease. So the trick is to know, are you at risk? Do you have high blood pressure? Do you have diabetes? Do you have high cholesterol? Do you have, like myself, do you have a strong family history of heart disease? All of those are putting you at risk as you age for having an event. And if you have those risk factors and you have some unusual symptoms, you need to think heart first, not last.
So you just mentioned all those different, factors that women have. So can I tell that I have heart disease? Like, I mean, how can people tell if we have it?
Well, of course, you can work with your primary care provider to identify where you stand on that spectrum. What is your blood pressure? Know your numbers. What is your cholesterol? What is your blood sugar? Of course, how many cigarettes you smoke should be 0. That's a big number. Yeah. But there are also some non-invasive tests that your doctors can do, something called a coronary artery calcium scan or carotid ultrasound, to see whether or not you have the beginnings of any plaque. And the beginnings of any plaque is kind of like being a little pregnant. You have plaque, and we need to stop it, arrest it, and in some cases we could even plan to reverse it.
Great, thank you so much. Dr. Dunsmoor-Su, can you tell us why women are most at risk for heart disease?
I'm happy to talk about that. I think we have a graph to put up. This is an interesting graph. I was recently virtually at the North American Menopause Society meeting, and one of the cardiologists presented this graph that shows sort of back in the 80s when women's cardiac disease deaths surpassed men's. And it's not necessarily that women have a higher risk at baseline, but that after menopause, our risk rapidly climbs and meets men's risk. And the problem is, for years, medicine assumed that women were at lower risk or that they behave differently from a cardiovascular perspective. So we didn't study heart disease in women, and we didn't treat them with the same medications after a cardiac event. In this graph, basically what you're seeing is that after a cardiac event, especially starting in the 80s, men would get statin medications to lower their cholesterol. They would get medications like ACE inhibitors to lower their blood pressure, and they would get great treatment for cardiovascular disease. But often women's cardiac events either weren't recognized, or even if they were recognized, because women tend to have more microvascular disease and you couldn't see the big plaques, they wouldn't get those medications and they would go on and have a fatal event. So why don't women and their doctors recognize their cardiac event? First, they don't always recognize that they have the risk factors. A lot of the risk factors that Dr. Speck just talked about. But one of the biggest risk factors that women don't realize they have are pregnancy complications. And I'm not just talking about high blood pressure in pregnancy or cardiac disease in pregnancy, but preterm labor, miscarriage. All of these things can lead to a risk of heart disease in later life. So knowing that you have these risk factors from back in your pregnancies is really important, and really important to transmit to your physicians.
Wow, that's very fascinating, actually. Dr. Speck, what are factors that can be more common in menopause that can contribute to increased heart disease?
Well, those are very important. Let me just add one comment to Rebecca's very pertinent comments before, is that 1 in 9 women at age 45 will have some form of heart disease. By 65, that's 1 in 3. As opposed to men, 1 in 5 men at age 45 and 1 in 2 men at age 65. And by 85, we are surpassing men. So menopause becomes a very hard stop to look at what my cardiovascular risk factors are. As we lose our natural estrogens, we know that hair changes, eyes changes, skin changes, our bodies change considerably, and our blood vessels become more vulnerable to developing inflammation, which is the background or the environment, if you will, where plaque can accumulate. So again, 60% of women at age 60 will have high blood pressure just because they got there. 70% at age 70, 80% at age 80. So clearly, menopause, loss of estrogen, and the bodily changes that happen predispose us to having high blood pressure, which is a significantly important risk factor for heart attacks and strokes, I might add. As we lose our natural estrogens, we make more of the LDL, the lousy cholesterol, that which builds plaque, and less of the HDL, the healthy cholesterol, which protects us from continuing to accumulate plaque. So these are very pertinent biological changes which occur just with the fact that we have survived this long. And so I have women come into my office who say, I never had high blood pressure before. Well, that's because you were 58 last year and you're 59 and a half this year. And it's simply that. It's nothing you're doing wrong, but there are some things that you can do to try and prevent that. And I know we're going to talk about that a little later.
Great, thank you. Dr. Dunsmoor-Su, somebody asked about diabetes. If you manage blood sugar, does it reduce the risk?
So yeah, so that's actually a really important point. Diabetes, having elevated blood sugar and diabetes has a lot of effects throughout the body. First of all, having elevated blood sugars is a very inflammatory state to be in. And so that inflammatory state can impact your blood vessels throughout the body, whether that be in your heart, in your brain, in your lower legs, which can lead to blood clotting. It also high blood sugars can damage nerves, including the nerves that control your heart. So maintaining really good control of blood sugar in diabetes can actually lengthen your life and prevent cardiovascular complications.
Great, thank you. Dr. Speck, do you have anything else you want to add to that?
I would say, again, looking at the early pregnancy history, if you've had a preterm labor, if you've had diabetes, gestational diabetes, you are more prone to developing diabetes later in life. If we all put on the extra 10 or 12 pounds post-menopause, we're more prone to developing what's called adult acquired or type 2 diabetes in life. So again, being cognizant of this, being aware of it, finding a provider that is also cognizant and aware of it and who will work with you to prevent your risk and lower it is really where you want to go at this stage of your life.
That's great.
Not to mention the 10 to 12 pounds we've all put on post-COVID as well.
Amen.
Exactly. Good point. So this actually is a good segue in terms of important interventions. We'd like to now have a poll and ask all of you, what is the most important intervention you can make for heart health? The options are to stop smoking, to improve your diet, exercise, hormone replacement, and fish oil. I believe for this one, you get to just pick one, and you have to pick the most important one. So while you're answering the question, Dr. Dunsmoor-Su, I have a question for you. By the time I reach menopause, is it too late? Have I done damage already to a perhaps less than perfect lifestyle?
No, absolutely not,
Okay.
Lorna. And that's something I emphasize every day when I'm seeing patients in clinic, because it can be, we all know what the ideal is, and none of us have lived that ideal. Especially when we were in our 20s and 30s and we were invincible, we were all doing things we shouldn't have, and that's fine. Many of us exercised through that, but we didn't always eat the best we could, and some of us were smokers. What I tell everybody is a great example is quitting smoking. So say you quit smoking today. By 1 year after you've quit smoking, you've halved your risk of cardiovascular disease. And by 15 years after quitting smoking, you're back to a baseline risk for cardiovascular disease of someone who never smoked. So you can always make a change that can improve your risk factors for cardiovascular disease. And today's the best day to start doing it.
Thank you. And I know we're going to touch on drinking too, so we'll get there, but it definitely is a question that keeps getting asked. Thanks everyone for filling out the poll. Why don't we check what the results are? So the question is, what is the most important intervention that you can make for heart health? 37% of you said to stop smoking, 31% said to improve your diet, 31% said to exercise. Nobody chose hormone replacements, and nobody chose fish oil. So Dr. Speck, can you tell us what the most important intervention is?
If you are a smoker, the single most important thing you can do is throw away your cigarettes, throw away your chewing tobacco, throw away your cigars. It's actually quite interesting that if a nicotine patch, chewing Nicorette gum is not the same risk as vaping or as taking the impurities of tobacco into your lungs. That creates a very inflammatory environment. And remember, it's inflammation which is the key to causing heart disease in the first place. Even if you have normal cholesterol, even if you have normal blood pressure, if you have conditions that cause inflammation. Now, having said that, if you're not a smoker, it has been said that being sedentary, i.e. lack of exercise, is the new smoking. And again, people who do not exercise regularly, and what I'm talking about is moving the big muscles between your waist and your knees, not the one that pushes the mouse around every day, okay? The big muscles between your waist and your knees for at least 30 minutes. And you can walk, you can dance, you can ski, you can do Zumba, you can do anything. You don't even have to break a sweat. You just have to move those muscles. And that gets rid of this inflammatory milieu, if you will, adequately to start to protect you from heart disease. And the literature is very clear that if you do 10 minutes 3 times a day, it's just as good as 30 minutes all at once. For those of us who are, so for those of you and for those of us who are, quote, multitaskers, where we can't seem to carve out that 30 minutes, 10 minutes when you get up in the morning, 10 minutes before you start to make dinner, 10 minutes before you go to bed, just as good.
Great. I know that somebody had asked, counting steps has been, a factor, and I know we'll probably go into this later, but I just want to plant that, seed about how many steps one should take.
If you do 10,000 steps a day, it takes a while, right? I mean, yeah. So depending on how big your stride is, that's going to get you close to at least 20 minutes of regular exercising.
Okay. That sounds great. Dr. Dunsmoor, so thank you, Dr. Speck. That was very, very insightful. Dr. Dunsmoor-Su, one of the questions is, I have seen that HRT can cause heart attacks or stroke, and it is protective, which is true. But of course, before you answer that, can you tell us what HRT is?
Absolutely. I love to talk about HRT. It's what I do every day. HRT is hormone replacement therapy. And what we generally mean by that is replacing estrogen and or progesterone after the natural menopause or a surgical menopause, if that's how you end up in menopause. The reason I say and or is that women who do not have a uterus don't need to have the progesterone replaced. That's really a protective hormone for the uterine cavity so we don't develop endometrial cancer. So we're really sort of talking about, well, what is the effect of estrogen? Because estrogen is sort of the hormone that we think of in terms of cardiovascular health. And the answer is, it's complicated. We have a lot of studies that say a lot of different things. And like Dr. Speck, I have a background in public health. I also have a degree in epidemiology and biostatistics, and I've read all these studies, and they're complicated. I think the simplest way to say it is that estrogen before the menopause is protecting us from a cardiovascular perspective. Our blood vessels are more pliable. We have better cholesterol parameters. We're less likely to have plaque in our arteries. And so a lot of studies were done to try to prove that continuing estrogen into the menopause would confer additional protection. Unfortunately, a lot of those studies were done in a way we would not prescribe estrogen. So these were women who were brought into the study and randomized to take estrogen or not. And some of them were as many as 10, 15 years out into menopause when they were randomized and started on hormone. The other side of the story is that estrogen can increase blood clotting. And when you increase blood clotting and you already have arteries that are damaged or have plaque or are less pliable, you're going to get more heart attacks and more strokes. And that's really what we saw in some of those studies. When you dig deeply into the literature, what we see is that starting estrogen replacement at the time of menopause, ideally within 18 months, but really you can have up to about 5 to 10 years, you're much less likely to have cardiovascular events. And there seems to be some protective effect. The other key component is that all of these previous studies were done with oral estrogen and oral conjugated equine estrogens, which is an older form. We more commonly use estradiol nowadays, which is considered bioidentical. We use only FDA approved versions of it, so we know exactly what we're getting. And we use it transdermally, which seems to have a lower risk of causing blood clotting. So using more modern hormone replacement therapy seems to confer more protection rather than risk.
And forgive my ignorance, but transdermal Is that the term?
Transdermal, sorry, that's through
Dermal,
your
okay.
skin
Through your skin, okay.
using
Thank
either
you.
a patch. Most commonly, it's a patch, but there's also a
Okay.
gel and a spray that can be used.
Got it. Thank you for explaining that.
And I think what Swedish is hoping to do with this approach is to say, okay, we're going to give you estrogen. There is some increased risk. We all have to recognize that. It's of benefit you. So just like any therapy, you're weighing the risks and the benefits. So what is your cholesterol? What is your blood pressure? You can't smoke and take hormone replacement therapy. Are you exercising? You know, what kind of food are you putting in your body? So that we can control all the risk factors that we can to reduce your risk of heart disease in general, and then any added risk that hormone replacement therapy may present to you personally.
That's very fascinating, actually. Thank you for explaining that. Dr. Speck, along the lines of prevention, diet seems to be something that we keep hearing about, like a heart healthy diet is what we hear. Why does that answer keep changing? Because I remember when my parents started talking about heart healthy, it was the big thing was, whatever it was, apples. And then today it's a lot different. Could you talk about the heart healthy diet?
Sure, it is very confusing. And of course, as all of us know, one size never fits all, right?
Okay.
So if you are overweight and have diabetes, eating a lot of carbohydrates, even though they may be healthy whole grain carbohydrates, may not be what your doctor recommends or your nutritionist recommends. They may recognize that you have more protein and more fruits and vegetables as your source of carbohydrate, so-called paleo diet, right?
Mm-hmm.
So-called keto diet. And doing that under some guidance for a finite period of time makes some sense because it improves your other major risk factor, your diabetes, your blood sugar, you being overweight, potentially having high blood pressure. But the diets that have been studied, that have been shown to not only prevent heart disease, but also potentially reverse plaque in your arteries, are the Mediterranean diet and a plant-based diet. So the Mediterranean diet has been studied extensively, and essentially it is 5 servings of vegetables every day, 5 servings of fruit, and getting your animal protein primarily from chicken, turkey, and fish, and eating fish at least twice a week, and having only whole grains as your source of carbohydrates that are not from the fruits and vegetables. Now, a serving is a half a cup, right? So you have an apple, which is what your mother said. You get 2 servings of fruit, right? You have a healthy salad, throw in some craisins, throw in some nuts. You can get there fairly easily, particularly since we're so fortunate to live in the Pacific Northwest, where we have an abundance of fresh fruits and vegetables almost all year round. Mm-hmm. A plant-based diet is sometimes prescribed for people who have very high cholesterol or who have had extensive heart disease, because the only source of cholesterol in our diet, the only source of saturated fat, which is the fuel that your liver uses to produce your cholesterol in your body, is animal sources of protein that are tied to animal sources of fat. Mm. So fats that come as liquids like olive oil, canola oil, avocado oil, nut oil, fish oil, those are all healthy fats. But fats that are globbed onto a chicken breast or onto a piece of pork are not. They basically serve, again, as fuel for making cholesterol in your body. But the other thing they do is, even if you're taking cholesterol-lowering medicine, as they're going through your bloodstream, they act like a Brillo pad to the inside of your blood vessels and scrape them and cause inflammation, again, which is the environment where plaque can start to accumulate. So long story short, Mediterranean diet, sometimes it's called the omega diet. Mm-hmm. There are lots and lots of resources out there. I would steer you toward the American Heart Association site, the Go Red for Women site. They have recipes, they have sources to go to. The other thing is that the Swedish Foundation very kindly last year several years ago, put together Heart and Vascular Institute Swedish Heart Healthy Recipes. And we were so fortunate to be able to get some really key chefs in Seattle who at that time were running their own restaurants, like John Sundstrom from Lark, Ethan Stowe, William Belikas formerly from Mistral, and also Kelly Stowe from, rather Kelly Smith from Cafe Juanita. We were able to get these chefs to create a Mediterranean meal for us. And it basically shows you how to make it, what the ingredients are, and then of course, how to enjoy it. So I would very much steer you toward that, particularly in the days when we can't go to a restaurant and we're all
Right.
trying to make healthy meals for our family.
Well, thank you so much. You know, that I love the Mediterranean diet, so that's great for me, and hopefully it will work for others. We'll have this link available at the end of the our time together, and we'll also send it out to each of you. So if you don't want to jot anything down, we'll have that available to you. So thank you for that. Dr. Speck, can you then, okay, so we should essentially be talking to our physicians about what will work best for our personal, you know, health, since not one size fits all. What is that? Is the same approach about exercise the same, or, you know, in terms of, let's say specifically optimal health in menopause, since that seems to be what we're focused on?
Again, I think our body stores our energy as fat, as carbohydrates, and as protein. We don't use our protein stores unless we are unfortunately truly starving. We therefore can switch off between fats and carbohydrates. Carbohydrate stores are finite in our body. There's only so many places that we can store carbohydrates in our liver and our muscle tissue. And so we store our extra energy as fat. When we burn fat, we are improving our heart health. We are reducing our insulin resistance, and so reducing type 2 diabetes. We are improving our cholesterol, and of course, we're getting rid of fat, right? So, so we look better. And that is most often accomplished as moderate aerobic exercise, and that's the kind that I'm talking about. You don't have to buy a gym membership. For even today, especially today, you don't even have to sweat. You just have to do it on a regular basis. So you're telling your body, don't store that extra energy. I'm going to use it for energy for my muscles. That's number one. Number two, of course, is as we go through menopause, and Rebecca can certainly speak to this also, we start to lose our bone density. And so it's very important to incorporate some kind of strength training. And again, it's not bench pressing your weight. It's basically using 3 to 5 to 8 pound weights on a regular basis, at least twice a week, to exercise those big muscle groups, the ones that support your spine and your hips, which is of course where osteoporosis can attack and give us untoward fractures and make the last years of our life quite miserable from either a hip fracture or a spinal fracture and a lot of pain and disability. So it's important to incorporate both. And in my practice, we have an exercise physiologist who looks at you, looks at what your goals are, looks at what your health goals are, and then tries to tailor an exercise program for you. That can also be done with, again, through the Heart Association, some videos, some suggestions for regular types of exercise.
Thank you very much. Yeah,
I just wanted to add, Lorna, you make a really good point, Sarah, that it's really that weight work, that resistance exercise that a lot of women are missing. Now, we tend to be better at the cardiovascular. We've heard over the years that we need to have that cardiovascular exercise. But as we go into menopause, we lose both our bone mass and our muscle mass. And to build that back, we really need to be doing that resistance work. And it doesn't have to be heavy resistance. Like you said, you don't have to bench press. Squats are great. Squats with a kettlebell are even better.
Sure. Thank you so much. So we have some questions. Are you both up for answering some?
Absolutely.
Sounds great. So one of the questions that we received is the pill dangerous for the heart? How does that impact estrogen? Dr. Dunsmoor-Su, do you want to take that one? Or, I mean, you both can, but.
Yeah. I'm happy to. And I'm assuming by the pill, we mean birth control pills or oral contraceptives, sometimes called OCPs. There are a lot of ways we refer to those. And the answer is, in general, no. Now, the estrogen in the birth control pill can increase your risk of blood clotting. So in that sense, there is some baseline risk from that of both getting a blood clot in your leg, which could go to your heart or your lungs, or if you already have established cardiovascular disease, then forming a blood clot on top of those vascular disease, those vascular injuries inside the heart could hurt your heart. But in general, when used correctly in the right candidate, in the right years, the birth control pill, no, should not impact your heart or your long-term cardiovascular disease. And that's a really important point because we do often use birth control pills to transition women through the perimenopause. Because when you're early on in that menopausal transition, before you've stopped your periods and before the estrogen has gone way down, if we were to give you a low hormone replacement dose of estrogen, it doesn't really work. The ovaries will override it. The ovaries still need more to sort of suppress them and take control. So, you know, we'll often use birth control pills in a woman's 40s to help get her through some of the fun of perimenopause. And yes, that is a safe thing to do.
Great, thank you. So I have another question, and I'm going to just read it how it was presented. Okay, so estrogen at menopause may be helpful in preventing a cardiac event. How long should it be taken? Years? For life?
That's an excellent question, and one we have not fully researched. I'm going to qualify. What we believe to be true is about 5 to 10 years is ideal. I do have several patients who I maintain on estrogen into their 80s because they feel good on it and it's making them, they feel healthy on it, and that's fine too. There is no stop date for estrogen, and even the North American Menopause Society is quite clear that says estrogen should be taken by women as long as it is functional and helpful to them to take it. There's no set stop date. But as best we can tell from studies, it's about 5 to 10 years of use that confers protection.
Thank you.
I would just add that if you choose to take estrogen beyond that limit, again, you want to work with your provider to say, okay, I'm going to get myself a coronary artery calcium scan to see if I have any plaque, or I'm going to get myself a carotid IMT scan to see if I have plaque, and then after I've been on estrogen a while, and my blood pressure is good, and my cholesterol is good, and I'm not smoking, and I don't have diabetes, but I have progression of plaque, well, maybe I need to think about getting off that estrogen. So it's multifactorial, and I think that the idea is you know that there's a risk, you're aware of the risk, and you're monitoring what the risk is, because the risk changes over time, just like you do.
Thank you. Another question is, I have postmenopausal patients who are taking progesterone, hopefully I'm saying that right, either tabs or cream from other providers, sometimes naturopaths, for their bones, hot flashes, or well-being. Is there any recommendations for this?
Yes, there are a lot of recommendations for this. And I'm not going to be able to go through all of them right now. What I typically would recommend is that progesterone taken in an FDA-regulated manner. So either as a progestin or as micronized progesterone from a pharmacy in the correct dosing is a safe thing to do. It is not typically the hormone I would prescribe for the bone health, and for the hot flashes, estrogen does a better job of that. Progesterone can be helpful in those situations, but really if you're looking at balancing risks and benefits, progesterone is probably not your best choice for doing these things. The other thing I always warn my patients about is when you're getting progesterone, especially a compounded progesterone, especially if they've taken that micronized progesterone and compounded it into a cream, you're not absorbing it well. So progesterone is a huge molecule and it does not absorb well through the skin transdermally. Progestins, which are different molecules, so like levonorgestrel and norethindrone, those can absorb through the skin. But if you're getting a compounded product, it's probably progesterone probably being applied to the skin, and that actually does not work to protect the uterus and won't be doing the things that you want it to do anyway.
Thank you. Does yoga count as weight resistance exercise?
Yoga does count as weight resistant exercise in some, depending on what kind it is. Yoga is also a significant tool for relaxation and for stress management, which is a factor that we haven't yet discussed. So I would say getting your bone health tested with a DEXA scan and making sure that you're doing enough resistance, and then following it along is the way to say, is my yoga enough strength resistance training for me? But yoga as a tool for stress management, for deliberate relaxation is terrific. And I would really advocate that all of us today all of us who are going through COVID, but certainly going through menopause, have some kind of deliberate relaxation practice. Because it's very clear that unmitigated stress is as important a risk factor for heart disease or strokes as having uncontrolled high blood pressure or being medically obese. That's how powerful the chemical reaction to stress is. And clearly yoga, Tai Chi, mindfulness meditation, any of those practices on a regular basis can mitigate that biochemical turmoil.
That's great, thank you. Somebody has sent in 2 questions. Is there a natural way to maintain your estrogen? Eating natural, quote, estrogen foods, if they exist. And then we can do the second one afterwards.
Okay. So the answer is there are foods that contain something called phytoestrogens. And phytoestrogens look a bit like estrogen in chemical structure, but differ from it in significant ways. And most of the phytoestrogens in foods, and people tend to think of soy as a common one, but there are others, are not really easily elaborated into functional estrogens in the body. In fact, most women just don't have the enzymes to do that. Even if you do have the enzymes to do it, they're elaborated at very low doses and they're very poor binding to estrogen receptors. So in general, no, there is no natural source of estrogen. As I like to say often, there's no estrogen flower. We got to get it from a lab. It's synthetic. So no, there's no natural thing you can do to maintain your estrogen. It's really, you sort of have to turn to hormone replacement if you want it.
Great, thank you for clarifying that. And then the second question is, why are so many women against hormone replaced therapy, HRT? Would you go for it? Is there a way to avoid it?
So why are so many women against HRT? I think there's been a lot of press about risk, press that isn't really necessarily true. And I think there have been a lot of studies that have published claiming risks that maybe aren't there. I just think there's a poor understanding of the risk-benefit ratio of hormone replacement therapy. And every time you take any medication, including hormone, it's a risk-benefit ratio, and you just have to have that conversation and discussion with your physician. Would I go for it? Yes, totally. I go for it all the time. I prescribe it daily to patients, took estrogen for a while myself. So yes, I would definitely go for it. And in terms of, is there a way to avoid it? Well, you know, you don't have to take estrogen. No one has to take it. We make that decision based on your symptoms and as well as what health gains you're looking to make with the estrogen. And so, yes, you can avoid it by not taking it. But for some women, that's not an option. They need it for their symptoms. They're that bad. And for some women, it is a good choice, especially women who have a really severe osteoporosis history in their family. It might be a choice they make for that reason alone.
Great. Thank you for explaining that. This next question, I might pronounce it incorrectly, so feel free to correct me. What about compounded estradiol vaginally to help prevent UTIs?
So we're talking about a different way to use estrogen in that sense. You do not need to compound it. Again, compounding hormones is not a safe choice. If you're worried about any risk from hormone, the last thing you want to do is be unsure of the dose you are taking. And what happens in compounding is they take the same synthetic estrogen or estradiol that I would prescribe you, grind it up and mix it in a cream. So you never know exactly what dose you're getting at any given point. And there have been studies done that shown that it can have anywhere from 19% to 268% of what it says the stated dose is on that package. So you don't know what you're getting in a compounded product. There are reasons to use compounded pharmacies, and I use them rarely for those reasons. But there are great estradiol products that are made and FDA regulated that you can take vaginally to prevent UTIs or to help with frequent UTIs. You don't need to compound this. There's an estradiol ring, there's an estradiol gel cap, there's an estradiol tablet, and there's estradiol cream that you can get from the pharmacy. And those do work really well in that situation.
So that has to be prescribed, it sounds like?
Yes, all of these are prescribed. Yeah.
Okay, great.
Let me just, typically they don't have a lot of absorption into the bloodstream. So you're not getting true hormone replacement doses that again would potentially put you at risk or not for heart disease.
Yeah, those are very specific products used for vaginal symptoms, pain, dryness, UTIs, things like that. They don't absorb into the system. In fact, most of them are so low that they're actually considered safe in women who've even had estrogen receptor positive breast cancer.
Great. Great, thank you. Another question is, I have an elevated lipoprotein, I think LPA count, and I'm curious if there are extra precautions needed because of it.
So lipoprotein A is a genetic characteristic, if you will. It accounts for about 20% of people, 20% of families who have a strong family history of early heart disease. That is, someone who's had a heart attack or a stroke prior to the age of 50 or 60 years old. It basically puts a corkscrew on the LDL particle and makes it very, very aggressive in being able to form plaque by penetrating the wall of the blood vessel and causing plaque formation early on. So when we see someone who has lipoprotein A, as a cardiologist, we want to be very, very diligent and very focused in trying to say, do you have any early plaque, by doing some of those imaging studies that I talked about? And what are your cholesterol parameters? Can we get those down as low as possible? Everybody on this call should have an LDL cholesterol, the lousy stuff, less than 100, and an HDL, the healthy stuff, greater than 50. So are you there or not? If you're not there, let's get you there. And that can be a combination of diet, exercise, and potentially even some medication. Because we know that lipoprotein A puts you at an independent risk of heart disease as you age, regardless of what your cholesterol is. So we want to control what we can early on and be aggressive.
Great, thank you. So if you have more questions, please feel free to type them in the Q&A box. And we have a few more before our time ends today. So this is something that I'm also interested in, is can you talk about sugar and how that affects both menopause symptoms and heart health?
I'll start with menopause symptoms and leave the heart health to Dr. Speck. We touched on it briefly before, but I'm more than happy to talk about it again. So sugar, the consumption of sugar does not directly necessarily impact menopause symptoms. What impacts menopause symptoms is having an elevated blood sugar. So if you have a diet that's very high in sugar, if you're pre-diabetic or diabetic, then you may have enhanced menopause symptoms, as we like to say. We tend to see more hot flashes, more night sweats, more insomnia in people whose blood sugar is riding high. And I think a lot of that has to do with the inflammation that comes from that. Does the consumption of sugar in your diet directly do that? No, there's a huge interplay between genetics and how you process that sugar and how your body is able to take care of it. But in general, a lower sugar diet and a lower processed carbohydrate diet is going to be healthier for you and less likely to bump your blood sugar.
Great, thank you. Dr. Speck?
Yes, I would underscore that sugar itself is in many, many products, whether they're processed or not processed. So sugar is in an apple, sugar is in grapes, sugar is in wine, sugar is in bread. So it basically when you get carbohydrates or you get sugar, it depends on what is surrounding it, how is it presented to you. People who eat a lot of processed foods, white bread, white sugar, a lot of sweets, they pump up their blood sugar level. They have to excrete a lot of insulin from their pancreas, which is the hormone that protects us, quote unquote, from developing diabetes, but can become exhausted over time and create a shortage of insulin or an inability of our insulin to respond appropriately, so-called type 2 diabetes. But even people who are pre-diabetic, if they have very high insulin levels because they keep challenging themselves with a lot of sugar, the insulin itself can be inflammatory to the lining of the blood vessel. And so again, can set up that environment in your heart blood vessels, in the carotid blood vessels that supply your brain, in the peripheral blood vessels that supply your legs, that inflammatory environment where plaque starts to be invited to form.
Thank you for explaining that. We've got two more questions. This is actually a really interesting and good one. We've got a few more questions. Do you have any thoughts on misdiagnosis of heart disease in women? According to statistics, 50% of women get misdiagnoses with anxiety instead of heart disease, even after ECG and other heart tests.
I would say that that statistic is not inaccurate, unfortunately. Part of that is because women are still, unfortunately, not considered as seriously when they present with symptoms as men are in a certain age group. So one needs to find a provider who takes you seriously. Number two is that, as Rebecca said, there is a condition called microvascular angina, where there isn't an accumulation of plaque necessarily in one single portion of the blood vessel that supplies your heart. So the exercise stress test can be quite misleading. But basically, the blood vessels look like bucatini pasta, right? The pasta that has a thick wall with a little hole in it. So there's sort of thickening and inflammation all the way down, and the blood vessels don't behave normally. Mm-hmm. That is a diagnosis that is sometimes a diagnosis of exclusion almost, because, again, the standard test can be very misleading, and so it takes repeated presentations and repeated focus with a particularly good provider to make that diagnosis. But that doesn't mean you shouldn't keep trying. Now, having said that, microvascular angina and regular angina or regular heart disease are still treated by controlling your blood pressure, your cholesterol, your stress levels, your not smoking, your diabetes. So the approach is the same. If you have those risk factors and you're having symptoms, keep seeking assistance.
Great,
and
thank you.
Sarah makes a really good point, and I just want to emphasize it. Not only are women not taken seriously when they present with symptoms of heart attacks, women aren't taken seriously when they present with symptoms of pain or any other things. So if you as a woman are presenting with symptoms and you feel like they're not being taken seriously, it's time to seek out a provider who will take you seriously.
Mm-hmm. It's a very good point. The last question is a two-part. So I'm glad somebody asked it. Is alcohol good, bad, or neutral for your heart? And then the second part of the question, because I want to get this in, is talk about supplements. So let's talk about the alcohol first.
Alcohol has been shown in moderation, again, as part of the Mediterranean diet. Particularly wine has some anti-inflammatory properties. It has omega acids in it. Whole grains or grain alcohol has omega-6s. They can be more inflammatory. So if you're going to drink, we would probably push you toward wine than we would toward hard liquor or beer. No doctor is going to necessarily prescribe wine for you. We've gone over that. Just have a glass of wine, honey, and you'll be able to sleep better. I think we're past that. But again, wine in moderation. Wine always in moderation. It absolutely increases your risk for liver disease. It absolutely increases your risk for high blood pressure. It disturbs your sleep during menopause, in particular, if you drink too much wine. And the other thing is, it's like drinking chocolate chip cookies. I mean, it is not calorie free. So you have to manage it appropriately.
Although it is my favorite way to drink my chocolate chip cookies, I have to admit. I think you made a really good point, which is wine. Wine, a lot of women enjoy wine, and it's I think in moderation it is a good thing to do for yourself. But especially in menopause, especially in those transitional years, it can really significantly impact sleep. And when you impact your sleep, you impact your stress levels, you impact your inflammation levels. So it might be a time to take a miss on the wine for a few years.
Okay. Can you touch on supplements? What are helpful in the prevention of heart disease, like fish oil, vitamin D, et cetera?
The best way to get your vitamins is through a healthy whole food diet, because there the nutrients are presented with micronutrients that can make them more bioavailable to your system. So a lot of supplements have been studied in heart disease: folic acid, vitamin C, vitamin E, fish oil, vitamin D, and really none of them in pill form have been shown to be helpful. Now, having said that, if you are an individual who has very high triglycerides, taking fish oil can be prescribed as a way to lower your triglycerides, which again improves your LDL and your HDL cholesterol as independent risk factors. Fish oil is sometimes prescribed in individuals who have had a stent put in or some other device to, again, as an anti-inflammatory. But the best way to get fish oil is to eat salmon twice a week.
Great, thank you. Thank you.
And that's, there are a lot of people who ask questions about supplements in menopause for similar reasons. And my answer is always, if you eat a well-balanced Mediterranean diet, you probably don't need a whole lot of supplements. If you know there are holes in your diet, then that's a reason to maybe explore that. So say you don't eat meat at all, or you don't even eat fish, then fish oil might have a role. But like Dr. Speck said, salmon is the best way.
And we're in the right area here.
What about vitamin D, Rebecca?
So vitamin D is a little bit more complicated because I think we tend to recommend it, but we don't have great data to back up those recommendations all the time. Vitamin D is best gotten from sun exposure, but then sun exposure can also give us melanoma or other skin cancer. So we're always making that balance. You can make vitamin D naturally, but in the Pacific Northwest, that's hard to do, especially come December, when there just isn't any sun and it's at too low an angle to really do any good anyway. So I do often recommend that my patients who don't get sun exposure, patients with darker skin, might want to take a vitamin D supplement because they're just not going to be able to elaborate that vitamin D using sunshine in the Pacific Northwest. And vitamin D has lots of roles, not only with heart disease, but also with bone health, possibly with mental health, although the studies are very mixed on that, and may even ease menopausal symptoms. So that's one that I'm more likely to recommend than most.
Great. So I just looked at the time. Gosh, it went by really quickly. And I think that that's a good sign. Thank you so much, everybody, for the questions. So we'll start wrapping up our time together. Dr. Speck, do you have any short concluding thoughts before we say goodbye?
What we know about heart disease is that 20% depends on your genetics. If you have a family history like mine, you need to pay attention to that. But the good news is that 80% is something that we can do about. 80% of that risk is in our hands to be able to control and to reduce our risk of not being able to watch those kids walk down the aisle, or not being able to watch those grandkids graduate from high school, and not being able to have a healthy 80-year-old, 90-year-old life. So I think this is a time to pay attention. This is a time to be proactive and to take time for you. Most of the time, we are so good at taking care of others. We've been trained all of our lives to think of our family first. When we are in menopause, we're taking care of our parents, we're taking care of our kids' teenage crisis. God knows what our spouse is going through. And we've got all that on our plate, but we've got to carve out some time for ourselves so that we can have a healthy remaining third of our life.
Thank you so much. Dr. Dunsmoor-Su, would you like to talk further about the Women's Health Specialty Center and any concluding thoughts?
Yes, absolutely, Lorna. And thank you so much, Dr. Speck. You make some incredibly important points about women finding time to take care of their health and their stress levels and all those things. Because if we don't take care of ourselves, we're not going to be able to take care of others. I love to talk about the center. I'm so excited about what we're building. We really want to have this center be a physical space, obviously, and that's hopefully going to be opening sometime in the new year. But also an overarching plan to care for women as they age gracefully in their 40s, their 50s, their 60s, and be able to bring together the level of expertise that you're seeing in this webinar with Dr. Speck, and in different specialties, including mental health, bone health, general primary care for aging gracefully, and just really have that available to women where you can have a holistic wellness plan for the rest of your life. That may include hormones, that may include cardiovascular treatment. It all depends. Everyone's an individual, so you'll be able to access all of those services either in the center itself or through referrals, because we'll have a built-in network. And I just want to thank the foundation, Lorna and the foundation, because what you guys do in raising money for things like this is really amazing. You know, without our incredibly generous donors, we wouldn't be able to open a center like this, and we wouldn't be able to support the vision that we have.
Thank you so much. If everybody could help me thank Dr. Sorensen, Dr. Dunsmoor-Su, and Dr. Speck for sharing their expertise with us. I hope that each of you will join us for our next webinar, which will be on healthy aging. And this will be on Tuesday, November 17th at noon. And we will be, as soon as this ends, you'll be getting a short survey. So we hope you can fill that out and share your feedback that you have of us so we can continue to improve and provide you everything that you need on being healthy. We appreciate you joining us, and we wish you all a great rest of your day, and please stay safe and healthy.
Thank you, Lorna.
Thank you.
Thank you.